really, when you think about it, it's around that education and assessment and the stuff that your clinical teams may already be doing and spending time with that patient.
There are so many justifiable use cases where we truly are rendering that assessment, evaluation, and management of something.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. We are back and couldn't be happier to be here. We're excited to share a new revenue recovery episode today. So in this episode, we will discuss CPT code 99211. What is it? When is it appropriate to use it? And its various use cases. As always, we have made a cheat sheet to the episode notes, hoping to make your lives just a little bit easier. And I am excited to introduce today's guest. Hopefully they are familiar to you, certainly familiar to all of us and for our Heart Talk listeners. We have Nicole Knight, Executive Vice President of Revenue Cycle Solutions and Care Transformation here at MedAxiom. Also, Linda Gates-Striby, MedAxiom Consultant, Revenue Cycle Solutions. Welcome back to the podcast, Nicole and Linda.
It's great to be back, Melanie.
Yeah, thank you.
So as a quick reminder, as a refresher, you can find the first 4 episodes this series in your podcast app under the Revenue Recovery title, and we'll also have links in the episode notes, so please keep that in mind. All right, Linda, I'm going to start with you. To set the stage, what exactly is the CPT code 99211?
Well, its official description is it's an office or other outpatient visit for evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. So when the AMA or Medicare uses that term, other qualified healthcare professional, they're talking about someone who has the ability to be credentialed and billed under their own name. So here we're talking about someone, that's why it's frequently called a nurse visit, because we're actually going to bill it under the physician or whomever is in the office, maybe the APP, under their name. So anytime we have a CPT code that describes to the payers what we do, we obviously need the diagnosis code or ICD-10 code that says why we did it. So since this person is not someone who would officially diagnose, you would assign the diagnosis as identified by that clinician that then most accurately describes the condition and medical necessity for that evaluation and management service.
All right, so the 99211 code is also, as you mentioned, it's been called the nurse code. What other professionals on the care team qualify to offer this service?
Yeah, when we talk about, those other folks, really, most importantly, you want to match scope of practice to that person. So it doesn't have to be the nurse visit. That's just sort of slang that's been used all these years. But it could be a medical assistant, it could be an LPN, it could be an RN, it could be a pharmacist. Really, it's any of those clinical support staff that are involved in some type of education and or evaluation and assessment. That a lot of us have those pharmacists now that are evaluating the patients and looking at their medical regime and what we may need to do there, but nursing education on things such as lipids or heart failure, or if a patient's new to a certain condition or they're unstable, anything that's going to help improve that patient compliance and patient outcomes, just matching it to the scope of care with the person rendering the service.
Okay, good to have that conversation with all those people so they know that this code's available. Nicole, let me bring you in the conversation. What is the average work RVU and CMS reimbursement payment for this code?
So, as Linda mentioned, for this office-based service, there is a Medicare physician fee schedule reimbursement for $22 on average. That's the national reimbursement. It may vary a bit with your Medicare carrier, and it does have a work RVU value of 0.18. So it's important to note that this is a billable service to the patient, and they could have an out-of-pocket co-insurance expense as well, but it is reimbursed by Medicare and by all other payers in our experience.
Linda, let me ask, what are the requirements for capturing this code?
Well, it needs to be provided by the clinical staff. And since we're billing it under the physician, that means that they're subject to the quote incident 2 guidelines. So incident 2 basically requires that the person who is providing the service is an employee or associate of the clinician, that they're going to be rendering this service to established patients only, and serving some sort of care plan that was established by the clinician. So that clinician and the staff, they're both going to be in the office at the time. Documentation, ultimately, it's suggested that it's reviewed and signed by the billing physician, and it is only eligible if your practice is considered to be an office site of service. We know there are times when, the service itself, the practice has become a hospital outpatient department. Well, if they are considered to be that provider-based clinic or hospital outpatient department, well, now they're not eligible for this incident 2. So it does need to be, you need to be rendered in a office site of service. And then, of course, the medical necessity and documenting fully. One other little thing would be that, if maybe the patient has a scheduled visit to come in and see the pharmacist. And based on that, and in the course of that, the pharmacist believes that the clinician should also see the patient while they're there. Well, we can't bill both. So in the event that a higher service is rendered, so now you've got that non-clinician and then the APP or the physician. Now we bill only the APP or physician. You wouldn't bill both.
Okay, that makes sense. Nicole, what should our listeners know about coverage eligibility for this established visit, not requiring a billable clinician service?
Yes, correct. So it is billed under a clinician, the physician or an advanced practitioner, as Linda talked about, but it's a service that's provided by staff or clinical staff. So it's important to note that sometimes your payers have their own policies. So checking with your Medicare carrier for some examples around that and what they require for coverage of these services is important. Also, if you're performing it as a virtual service through telehealth, both audio and video, both the clinician and the staff have to still be in the office at the same time to be eligible. So that's really important as you're looking at this, and to know your payer policies to ensure coverage for your patient's eligibility of the service.
All right, great information from both of you all. And we aren't done yet, but it is a great place to pause for a quick message for our HeartTalk listeners. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back. We have been discussing revenue recovery with industry experts Nicole Knight and Linda Gates-Striby, specifically capturing established patient visits not requiring a billable clinician. So we do want to dive deeper on this subject so no dollar gets left on the table. So Nicole, what are some potential use cases for CPT code 99211?
Yes. So when you think about the services that your clinical staff is providing for significant education, for evaluation or assessment of that patient, those are the things you want to consider. And some use cases are a pharmacist that you may have within your office setting that's providing evaluation of their medication or providing any type of information around their medical regime. This can be captured as a 99211. Also, any nurse education on lipids, congestive heart failure, or if the patient's having any new symptoms or requiring additional education around their anticoagulation therapy. We often get asked about wound checks. What we say is wound checks that are not billable in the global period from our device implants. Those would be an example also of services that clinical staff may be providing. And really, when you think about it, it's around that education and assessment and the stuff that your clinical teams may already be doing and spending time with that patient. So meeting those requirements around the 99211 and supporting these potential use cases definitely helps with translating that into a billable service under their clinician who's providing their overall care and treatment.
Mm-hmm. Linda, while our listeners may or may not be the people literally coding these services, many are responsible for their program's overall success with revenue recovery. So give us your top implementation tips for capturing this service.
Well, one of them would be just scheduling it as a nurse visit. So it's not confusing to the patient that it's just any other phone call that we might get from the office, making sure that they do understand this is a visit,
Mm-hmm.
even if it's virtual. And as Nicole mentioned, like the wound check. Well, okay, maybe they call or send an email. We get bombarded with emails now, and they've expressed that they're a little concerned of a hematoma after an intervention. Well, that's a great time for the physician to respond back and say, let me schedule this as a visit with my nurse so she can actually look at your wound and schedule that as a virtual visit. Saves the patient a trip in, relieves them that it's okay and that someone's going to look at it. And that's not one of those that's in the global period. So scheduling it. And if the clinician knows, another good example is maybe a patient's heart failure or blood pressure is not under ideal control and they're going to make some medication changes. And they may do that at the visit with the physician, but then the physician may say, so I want you to take your blood pressure and your weights every day for the next, 3 to 4 days. I'm going to have my nurse schedule a visit with you
Mm-hmm.
on Friday, and let's see how you're doing with that medication change. So they know it's a visit, and you kind of set it up if the clinician's going to need that follow-up while they're seeing the patient, for a follow-up, but not necessarily in person. It's a great way to do it. And of course, that documentation that's going to need to include the nature of those services being rendered and make sure that that medical necessity is there. And then also, make sure we've matched it to their clinical scope of practice.
All right. So, Linda, you did talk about this a little bit, but Nicole, I want to ask you because we know it's so important in our Heart Talk community here at MedAxiom is to always bring that focus back to the patient, even when we're talking about money. So, how does appropriately capturing the service ultimately benefit the patient?
Well, this actually represents the care team that's helping to manage that patient and provide that proactive care to the patient. So the patient is really getting a sense of the overall involvement of the care team and that they're also integral in being proactive in managing their services. And this is just a way to do it where the physician doesn't necessarily have to be physically available, but that other members of that care team can provide those true points to manage that patient's care and treatment and also reassure the patient, ultimately helping them with the satisfaction and access that they need.
Mm-hmm. All right. So I do want to give you guys one more chance to add anything to our conversation that might help our listeners.
Well, I guess I could add, the 99211 was suspected of being abused, back in 15, 20 years ago, that people
Mm.
might say, well, while we're giving you your flu shot, and then they would bill for a nurse visit along with that injection. That's what I would consider, quote, documenting fluff.
Mm.
If that blood pressure wasn't pertinent, if that wasn't necessary, you don't just add fluff in order to try to meet the requirements of a billable situation. Same thing with just, a routine blood draw. If they're there for a blood draw, don't also bill a nurse visit. But as we've, mentioned numerous times, there are so many justifiable use cases where we truly are rendering that assessment, evaluation, and management of something. And that's the ideal situation for these services.
That's great. And again, it does always bring it back to the patient and making sure that we're thinking about them always. Nicole, Linda, thank you all so much for sharing your time and, of course, your expertise today on MedAxiom Heart Talk. Appreciate you both.
Thank you.
Thank you.
And that is going to do it for this episode. If you liked it, please tell your colleagues and let them know they can subscribe to MedAxiom Heart Talk on Apple, Google, or wherever they get their podcasts. Also, if you'd like to send us a note or even suggest a topic, email us at hearttalk@medaxiom.com. Thanks so much for listening.